We will get started. So as I said, welcome to our webinar tonight on Talking the Talk, Building Cooperative Relationships. And I'm going to just change over to our two presenters and I'll be introducing them. So Family Caregivers of BC, first of all, just to give you some context, we're a nonprofit charity dedicated 100% to supporting family caregivers. So we're very fortunate in BC to have a provincial organization, and we're funded by our Ministry of Health to provide webinars like this, and we have a call line. I'll be discussing some of our other services for all of the caregivers in British Columbia. So we're very fortunate. Our organization has actually been around for going on 30 years in 2020, so that's very exciting. I mentioned that we do a number of different things. So just what I'm going to suggest is that if you're new to Family Caregivers of BC, the best idea is to go to our website, which is noted here on the bottom of this slide, familycaregiversbc.ca. And what you'll see on the web is that we've broken our services into caregiver support, education, and collaboration and engagement. In terms of our caregiver support, we have a toll-free line that you can call from anywhere in British Columbia, and you will be connected to a caregiver support person. You are looking at two of them right now, who I'll be introducing, Wendy and Sheila. They take calls from caregivers. We help caregivers. First of all, we'll just listen, and then we help you navigate. We provide information and referral, and if it's really complicated, we'll do some coaching with you. So that service is available during the day, during weekdays, 8:30 till 4. We also help to create support groups throughout the province, and we have an extensive online resource center. So if you go onto our website and click on Caregiver Resources, we have handouts on all of the topics that you folks are interested in and ask us about all the time. Then, of course, we have webinars like the one that we're doing tonight, and I am recording this webinar, and we post the webinar recordings on our website. So if you want to share this with someone after tonight, you would just send them to our website and they'd be able to watch the webinar. And we have webinars that take place all the time. So if this is your first time, I encourage you to go onto our website, have a look at some of the webinars that we've done in the past, and keep an eye out for webinars that are coming up. We also have a quarterly newsletter, and so if you want to receive that digitally, you can sign up for that on our website. And if you do that, you'll get a monthly e-news with information that's relevant to caregivers. And last but not least, we're one of our huge passions is making sure that the caregiver voice is represented and heard at planning tables for health system change. And so we engage family caregivers to attend meetings, to become part of committees, to review materials for us. If this is of interest to you, if you know of anyone who might be interested, we are always recruiting family caregivers for that and would love for you to get in touch with us. And again, you can do have our unique caregiving experiences. So I'm very pleased to present our two presenters tonight. So Sheila, who you see in the upper box, Sheila has she's an RN. She's now retired, but not really, because she's working on, she helps us out part-time on our caregiver support line. But Sheila has an extensive career that has spanned the whole continuum of healthcare. And when we say that, we mean everything from community-based services through acute care, back into community, and she also spent quite a bit of time overseeing placement of care recipients into facility-based care. And Sheila, actually, I think it's from back east, but she now lives in lovely Victoria. And she really believes in addressing care recipients and caregivers from the whole person perspective. So we're absolutely so lucky to have Sheila here. Wendy, who I'm going to blow up here so you can have a look at her. Wendy she's a gerontologist and has her own company in the Comox Valley. She contracts to Family Caregivers of BC in a number of ways, and one of them is she's a caregiver coach. So if you have a complex situation, we would refer you to Wendy. She also does these webinars. She helps us with engagement work, and writes articles for us in the Inspire Senior Living magazine. So Wendy's a gem, and we're just thrilled. I think Wendy and Sheila are going to do a great job. Before I leave this slide, I just want to point out at the bottom of your screen, you'll see FCBC webinar handouts. When we post the recording of the webinar, we will also post these same handouts, but you can upload them right now if you want. You can upload them by just going to the upload file, and they'll download onto your computer. But just so that you know, the PowerPoint that we'll be showing tonight is included, so you don't need to be taking copious notes. So I'm now going to turn it over to Wendy, and Wendy and Sheila are going to take it away. And again, I'm going to be typing into the chat box, so please get chatty with us, and away we go.
That's great. Thanks, Janet. Well, it's lovely to be here on a Thursday evening, and thank you everyone for making the time to attend the webinar. It's really much more enjoyable when we have a diverse group of individuals, and although no pressure, it's great when you ask questions in the chat box, because it really helps bring your personal experiences to the learning objectives. I have to comment on one thing. Janet and I have been doing webinars for a number of years together, and it's very rare that a webinar goes without hitches. And I do have to just, I'm always sort of waiting with bated breath that these things are actually going to operate. Like, you'd think after 10 years of this technology that it would run smooth, very smoothly, but we've had instances where midstream, the screens go blank, and we're desperately trying to bring people back online. So fingers crossed for a smooth run this evening. I'm sure it'll be fine. So this particular webinar builds on a previous webinar that was called Accessing Community Resources, and that aired October 18th, and it's now available, of course, online. And so if you missed that webinar, you're more than welcome to go back and click on the link, and it'll take you straight there, and you can listen to it. What we're really hoping tonight to provide information on and support and to listen and to help guide is around how, as family caregivers, we can establish ourselves as part of the care recipient's healthcare team. And I would also argue, even if your family's not quite there either, just part of the care team. We're also hoping that we can understand where and who to go for healthcare needs, depending on where you're at in your caregiving spectrum. So whether the person you're caring for is living in community, or whether they're in assisted living or independent living, or whether they're in long-term care, there's all different ways to access information or to ensure their needs are being met. And I suspect one thing that is super helpful is how to speak the healthcare system language, and not necessarily understanding all the acronyms, but perhaps also around how to present information to the professionals that you're working with, and how to convey your message, and how to ensure that the needs of the care recipients are being met, and that they have an opportunity also to express it in a way that allows them to be heard as well. It's also really important that as a family caregiver, we know that we're doing the lion's share of the work, that if you have particular needs in terms of what support you require, it's also finding the right language to express that. And also just our general communication strategies that we hope anyone can use on the care team and the person that you're caring for. So that's what we're hoping to get out tonight, and we're really looking forward to sharing our experiences and hearing more about your experiences throughout the evening. Oh, and one more thing. So this will become more apparent as we go through, and I think Sheila will appreciate this. So I just recently got back from a vacation, and I was in one of the stores, and I don't know if people can see this or not, but I found this little Buddha, this little tiny Buddha that sort of represents a lot of patience and calm. And so now the little Buddha, every time I get a coaching call or I'm helping a client advocate for themselves, I keep it in my pocket.
Good idea.
So I brought it to the webinar tonight.
Excellent.
Oh, I actually can do it myself. Here we go. Okay. So one of the things that the reason why we're having this webinar is because we hear on a daily basis what caregivers are expressing. And we have a caregiver support line, and through the coaching calls that we work with, they often give us a window into what the concerns are. And so what we hear is, for example, caregivers aren't sure where they can step in, what their rights are, how do they start advocating, how do they formalize their role. They aren't always sure who to speak to about a specific situation. They're not exactly sure how best to approach healthcare providers, or even kind of who's who in the zoo and what their roles are. They're unsure about, the sequence of how that takes place in terms of at healthcare appointments, or if they're trying to initiate access to services, how to go about that, and who to speak with, and what those processes look like. And they often don't know if they've been heard or understood. So sometimes what happens is family caregivers often feel invisible because our healthcare system is geared, primarily towards meeting the needs of the client or the patient. That is slowly shifting, but often caregivers will feel invisible in the process, despite the fact that they are a huge part of the care recipient's overall well-being, and they take on the lion's share of the work. So I think there's a couple of misconceptions about our healthcare system, and one of the misconceptions that I often hear is that publicly funded services means that it's free. You get everything for free. But in fact, that's not the true, not the case. It's subsidized, it's funded. We're paying through our taxes. But there are services that, although are being subsidized, we still have to pay a per diem rate, or we have to pay a fee to have an application filled out, or it depends on the service. Sometimes people feel, caregivers especially, they're maybe a little reluctant to say, well, if we use a private system or a private care, we're not going to be able to access public, and that's not the case. I would argue that going forward, most individuals, if they have some extra means, they often will use both systems to help them be able to successfully meet their needs from a health and overall well-being. And the same thing, just if you are using private services, it doesn't affect your ability to access publicly funded services. Often what we find is that families or caregivers take a more strategic approach to how do they look at their overall resources in terms of, their informal resources, which is the unpaid people that are helping them, what's their current income status in terms of what they qualify for publicly funded services or nonprofit services. And then, if they have some additional resources, how do they best use that to complement, their current needs? And I think that's really important thing that this kind of misconceptions is that, I'll give you a perfect example, that everyone on the healthcare team is speaking to each other. So right now we have an individual who has Parkinson's disease, and his wife is caring for him. And, he was hospitalized last year, and they've just undergone a pretty major move. She has early signs of dementia. And so their daughter is trying to help them navigate and ensure that information is being translated. So just recently, he attended a specialist appointment with a neurologist, and the neurologist advised him to come off a medication. And so he did. And so that information went to his family physician. But 3 days later, he had an appointment with a psychogeriatrician, so someone who came in to deal with, kind of taking a look at how his level of cognition was, or if he was concerned about delirium, or some anxiety, and there hadn't been the information transfer that he had come off a medication that was related to his memory. And so there's this kind of misconception that each of the healthcare providers are speaking to each other, and in fact that's not the case, and it's often one of the major areas where information can break down. And that, I think, comes to the next point, where if you tell one person your story, you often have to tell that story over and over again to every single healthcare professional that you meet along the way. It doesn't get magically uploaded into a bank. So that's often a common, another sort of area that family caregivers are sometimes surprised to learn. Sheila, did you want to add anything to those points?
No, you captured them.
Okay. So I'm going to hand this over to Sheila, and she's just going to kind of review this slide on the map of healthcare services.
Wendy, I don't have a little Buddha, but I used to carry a little thumbstone in my pocket, and I used to have my hand in my pocket a lot, and I've lost my thumbstone, so I'm going to have to get something else to help me through those times. Yeah. I'm sure it's in my room, I just can't find it. So the map of the healthcare services, as you can see, there are 4 areas: the healthcare provider care teams, the other one is the Ministry and Health Authority supports, personal supports, and community supports. This little thing in the middle, the little circle in the middle, can actually twirl around, and they intersect with all of these various, with these 4 services can happen at various and sundry times. But as it reads right now, the healthcare provider care teams, it usually is direct care of the individuals and communicates as the key delivery mechanism for the healthcare system. So that would be when you're have some connection with the healthcare system. So let's just say an acute care event, someone lands up in the hospital, and the first people they come across, of course, are the intake people, taking all that information down that you think is going to get transferred to all and sundry, which doesn't always get transferred to all and sundry. And then you'll get started with the healthcare teams, and that can be very overwhelming at times, but those are the first people that you would meet in the event that your loved one or yourself had something happen and you were into the acute care system. It could be your family doctor. It just could be even when you're getting down to the community supports or the personal supports. It could be a case manager from the health authority. So the intersect can happen at any time. The Ministry and Health Authority supports, that's the programming that happens for the individual in the community and the system levels. That can be a real maze by times and very difficult to work through because you don't know who you're working with, whom you should contact, who's working with whom, and what system is intersecting with another system. The personal supports, that can be involved at any stage of care. For the caregivers, obviously earlier the better, but as I know from my experience in home and community care here and back east that it didn't always happen at the very beginning, and people waited a very long time until they were in dire straits before having some help through the personal support, some help in the home. The community supports, this is the source of the direct care and the support across the continuum, and this is for the caregivers, and again, earlier the better. However, again, it can happen at any stage. It could happen at the very, much later on after someone has been providing care for a loved one or a friend, whomever it might be, for a very long time, sometimes near that burnout point, and sometimes at that point in time, the care that the community support and the personal supports that can be provided aren't enough. And again, the caregiver is feeling quite overburdened. But we can hope that as through some of the information that we're giving you this evening, that you will be able to understand when and how to access some of these supports and services that are available. And certainly part of the problem in accessing any of these is lack of knowledge as to where to start, or being overwhelmed by not knowing where to start, or maybe given too much information or just little snippets of information that aren't particularly helpful. Almost need a roadmap to get through some of these systems. And I've worked in it for a very, very long time in various and sundry health authorities, and it's the same everywhere. It's very difficult to get the information that one needs as quickly as needed sometimes. So
I just want to pop in here and say, as I typed into the chat box, what Wendy and Sheila have been describing are the perfect times for you to call our caregiver support line. So what we so often find is that when you get stuck with what we call navigation, or you're just not sure what step to take next, that's where we can really help you. And even though we don't know your care recipient, if we listen long enough, we can usually give you some advice about a next step that might make sense, or refer you to another person that might be able to help. So, you know, it's never too late. That's all I'm going to say.
I was just looking at a couple of the comments, and I know we're going to get to some of these in the next slides, but I just wanted to bring it to people's attention that you know, one of the trending themes at the moment in the chat box is this idea of having to retell a story, and sometimes it's not just exhausting just to retell it, but sometimes it's emotionally exhausting as well, because you're often having to talk about, you know, pretty challenging situations, or you're having to maybe feel like you're throwing someone under the bus because their, you know, cognition is changing. And so it can be emotionally exhausting in that regard. So I certainly appreciate you know, the comments below, and you know, around what are some of the, you know, kind of easiest ways to present that information, especially when you're going to see a specialist. So one thing that I'll just quickly pop in here, and then Sheila, you know, feel free to pop in, and we'll explore this a little bit later. But one thing I often do is keep everything in a bulleted point, and try and have it in a timeline fashion if there's no specific things that have happened. And, you know, in terms of kind of a background of the situation, and then you know, and then actually giving that to the specialist, a written account of it, as opposed to having to retell the story. I often have that where I can just say, you know, here, and then it actually goes on file, and it helps serve as a conversation point as well. So that's just one tip to think about. I'm not sure, Sheila, if you just want to quickly respond to some of the things in the chat box before we move on.
Having a little difficulty. I got to get a little closer to the chat box.
Well, Kimberly is
at the table. I can't read the.
And some people may not, and we may have some people who've called in, so I'll just read it out. Kimberly says, how do we help the healthcare system appreciate how we are most often present to help our family member, not to judge, which is often the perception of the healthcare team. And if we do judge, it's often for good reason, because our loved ones' holistic needs are not being met and they are suffering in some way. So it sounds like there's a bit of a not feeling welcome to be there and bring forward concerns.
Yeah. I was actually going to touch on this a little bit later. Can we just leave that for the moment?
Yeah, okay, sure. Yeah, we'll come back to that.
I don't answer it. Kimberly, if I don't answer all of your question, you don't have all of the answers when I do get to it in a later slide, please just let us know again. That would be most helpful.
And we'll just take note that Vivian has a really good comment of taking screenshots or scanning any documents on her phone for backup, so she has it on her at all times. So that's great.
Yeah, that's really good.
So Sheila, I think you were just going to quickly sort of speak to this healthcare system at a glance. Just
It's going to be very quick. I'm not going to go into too much detail, but they are. There's the publicly funded, and yes, it's not all free, as Wendy had said. Can you make that a bit bigger by any chance? Either that or I'm going to have to move closer.
Let me see. I don't. Yeah.
My eyesight's failing.
I think I'm not sure.
No, it's okay.
I can just. Does that help?
That's okay. So the systems of healthcare, the public. So this is Canada Health Act services. This is the hospital and physician services that are provided to us through our funding is through the public. What's that say? Taxation. Sorry, I really am going to have to move a little closer.
Okay.
So it's funded across the country through public taxation. So that's what we're talking about is our provincial health insurance plans.
Yeah, and I think this slide was really just the purpose of this slide, and I don't think we need to go into too much detail. It's just to, as Wendy said before, we've got two main systems. We've got private and public, and if you're in one, it doesn't eliminate you from being in another one, but it's helpful to understand that there are these two different systems, and when you're in one versus the other. So I think that's really the point of this slide. And again, we have this the whole PowerPoint is going to be a handout, both on the website, and if you can download it right now, it's on, so you don't need to worry about this. So we're just going to move on.
Okay.
Because our main point is about where the intersects are between caregivers and the system and what happens.
So family caregivers intersect with family physicians or general practitioners, whatever your family doctor, whatever you call them, and specialists during appointment times. We intersect with the healthcare providers in hospital during acute episodes, and that again could be the nurses, the social workers, the therapists, whomever is providing care for us or our loved one during an acute stage while we're in the hospital situation. Also might run across the acute care liaison staff during discharge planning from the hospital stay or for an emergency department visit. You run across those folk in two ways. One, if the person is already a home and community care client or continuing health services client, I guess they're calling them now, or if some help is going to be needed in the home, then usually the liaison staff or the discharge planning staff will set that help up through the health authority, through their home care program. And then there's the community health providers who provide the support to the care recipient in the community. That again is usually through the health authority, and can be done either from acute care or from community. And then there's the facility placement staff that come into play and come into your world when someone is admitted to acute care or at home and are requiring long-term care, facility care, residential care, whatever they're calling it in your area, but it's long-term care. And that's in a what we used to call a nursing home setting, or it could also be assisted living as well. What basically is just they can't go home to where they are, they need a little bit more support, and they do assessments of the person's ability to manage their self-care, their cognition, mobility, etc., and whether or not they would be safe to be going home to their home or whether they do need more supported care. And the level of support is determined by the staff in hospital in consultation always with the family and the caregivers in that family situation.
And so I think our next slide.
Sorry. I just wanted to, can we just go back for 1 second?
Yeah, sure.
I know we're speaking directly about the healthcare system. I think it's also important for our participants to understand that they're going to intersect with other important healthcare professionals, such as a pharmacist, or if they're care recipients going to other rehabilitation or ongoing use of other ongoing services. And so they're also going to intersect in what the strategies we're going to connect with tonight, or ideas, can also be applied in those situations. I just wanted to mention that just because it is helpful to know that while it is most of the interactions take place in the healthcare system, they can still be applied in the greater context of caring. So, Sheila, did you want to speak to this slide, or?
No, go ahead.
So we just wanted to show really what it might look like for a family caregiver. Just kind of give you an example. Let's say an acute episode. You're in emergency or hospital. Typically, what the family caregiver their responsibilities often end up having to be, let's say, they have to, figure out medications. They have to get, equipment for home use when discharged. They have to look at booking up following appointments. They have to look at monitoring ongoing recovery. They're looking at attending follow-up appointments. So there's a wide, range of needs that a caregiver is often required to do. They have, trying to be present in those moments for discharge, trying to make sure they're speaking to the right person. And then all that information that happens after an acute episode, so when someone, say, gets discharged back into the community, is that it goes to the general practitioner. But let's say there's a follow-up with a specialist. Well, that information then needs to be ensured that it's being passed on to the specialist, or if the case manager is coming into the home to do an assessment, then it's ensuring that information is being passed on to that healthcare provider. And if, let's say, you're using, any other type of supports that fall within the health authority, you could have 1 or 2 or 3 different people coming to your home or to the place where the care recipient's living. And so it comes back to this point of, trying to have information that's very easy to transmit, and knowing who you're speaking to, and knowing how best to get that information across. So I often, Jan, I guess we as an organization often indicate that the family caregiver, I like to call them the quarterback, but they're also the linchpin or link pin, whatever term I use, that really kind of provides that role in terms of making sure that all that care coordination is being done, and that transportation is being looked after, medication, booking appointments, follow-ups, especially with a frail senior, but also with other individuals who are going through other chronic illnesses, or individuals who are caring for an adult who has a mental health issue. They really become that cornerstone of that person's, the care recipient's healthcare journey.
Yeah, and one of the other things is, you could use any, as Sheila was saying at the beginning, it could be, it's not acute care, it's you're in the community and you're dealing with healthcare providers, or, you're in a long-term care facility and you're dealing with providers. So this is just one example, but it tends to be, in transitions to and from that the greatest difficulties happen. And, as we were saying before, like that's when information isn't transmitted, or, there's assumptions about, did people get records, or was the caregiver involved in the discharge plan, as Wendy was saying. So I see some people are typing into the chat box here.
Well, we can move on to the next slide. So, I mean, I think what we're coming to before we get to some of the key strategies is that we understand that family caregivers often feel invisible, unsure, excluded, and so going forward, we're hoping that we can help provide some strategies. Okay, Sheila.
Oh, mine. There is huge value in building relationships, and sometimes it is very difficult to build these relationships, and it's sometimes time-consuming and tiring. And we have to recognize that the health care system is primarily designed for the person receiving the care. I think we would all agree with that. But family caregivers have the key essential information for their ability to care for their loved one. What supports there are, what the home environment is like, what the financial situation is, etc. And it's very important that when you're trying to build these relationships, so let's just take, we had the acute care example there a moment ago, let's just take that again into consideration. You have a loved one in the acute care situation, an event has occurred, they have to go home, or they're ready to go home or getting ready to go home, there's discharge planning starting. It doesn't usually start a day or two before the person's going to be discharged. It happens right from the very beginning, and that's when we're always looking at discharge planning from the very beginning of the hospital or acute care stay. Now, yes, there are ups and downs along the way, however, and that planning changes or gets put on hold, but it's still there, and it starts from the very beginning. So family caregivers are very important. Have a very important role in that discharge planning right from the very beginning. You're able to communicate to the healthcare team, to the nurses, the doctors, the specialists, whoever it is that you're dealing with, information about where your loved one lives, what the barriers might be if they are to go back home. Those could be physical barriers from the environment. They could be barriers due to your ability to provide the care. It could be the financial situation as well. All of that information has to be transmitted to the care team, and that's why when the hospital starts talking about discharge planning, it's very important that they have the family care care plan discharge meetings, and that the family caregiver is included in that and heard. So last point there, being seen, heard, and involved in the process is critical, and it will, and these are very true, will result in better care at home for your loved one and better support for you as a caregiver. If we can go on, we'll build on that.
Right. So
I just see some comments from the chat box as well. So I think we're going to keep those sort of in hand so we can specifically address those when we are going forward here. Whoops.
yeah.
So, and for Sheila, sorry, I tried to go forward here. Whoopsie.
Here we go.
So I do apologize because I may have mucked up on my slide. So in terms of becoming part of the care team, I think what we're going to get to in the meat of our presentation here is that in all cases, what we're trying to do is build cooperative relationships, and it's about how do we become a team member, how do we be a voice, how do we be prepared, how do we be realistic, and how do we be persistent and kind. And I think if it were just left up to us as individuals, if you could give us all the tools in the world and we could implement those, but it's not always black and white. Often where the challenges are is that the emotional side of caregiving enters into it. The person we're caring for has their own, needs and concerns and maybe some different communication styles. The healthcare professionals we're dealing with, they bring, their own set of challenges or their caught between a rock and a hard place in terms of what they can and can't do. Often things like perceptions around the person who they're caring for. So all that to say, with the strategy we're going to present, it's obviously going to be very different for every person's situation. So I just wanted to mention that piece before we got started. So being a team member, I think where the important piece is understanding where the care recipient is in terms of their own care needs to the healthcare system. So this is always a bit of a challenging piece because depending on the care recipient and their healthcare issues or where their cognition is at, or if they've had, say, they're living with an acquired brain injury, or there's a mental health issue, or there's dementia, or it's a chronic illness, their ability or capacity or desire to be able to direct their care is going to vary. And so the role of the caregiver then is going to have to be pretty customized based on those needs. Not to mention one's ability to, want to receive help from the healthcare system or receive help from, other individuals. So I think that's important to know where that is and where some of the challenges are, where you're making some headway is very important. I think, one thing that as team members we can do is starting at the place of where the care recipient is in terms of understanding what their own goals are for care and what possible actions one's looking for. And what I would say on top of that too is what your own abilities are as a caregiver. Like, what kind of team member can you be? So where are your boundaries? Where are your limits? Where are your strengths? And I think that's a really important piece too. So it certainly goes both ways. The idea of ensuring that the questions are that you have questions in advance and being prepared and even having done some research is really important. So you can be really concise with your information. I always like to say I put on, I do my best to keep the emotional side at bay and just focus on what the facts are. Because typically our healthcare system does better with, what the facts are, because it is designed to figure out, okay, if there's a problem, how can we solve it in terms of the diagnostic piece and the treatment piece. One of the biggest things around understanding the team member is who the right person is to ask. So if you get a phone call from an intake person and you start, talking about everything, only to realize that they were just there to collect some very basic information, then, you're having to repeat that whole story. It wasn't necessarily the right person that, you want to tell that story to. So one of the key things is making sure you're talking to the right person for the questions that you need answered. And the other piece, which I think we've been reading about here in the chat box, is this idea of a written record. And obviously, it's questions and answers is an important piece, but it's often usually an actual written sort of ongoing timeline or record of who you spoke to and what the conversation was about, what the outcomes were, and what follow-ups were required. So that's, you can kind of see how that ends up, you become a very important part of the team.
We have a few comments that people have been typing in. One of them, Dana, is kind of pointed out, Wendy, exactly what you're saying in terms of a written log with every visit to the medical team and how much that helped in the care of his wife who has breast cancer and is undergoing chemo. So thanks for sharing that, Dana, and we talked about that a bit. Yeah, and Kimberly was saying that for her mom, the adverse event was being sent home from acute care repeatedly without any follow-up plan. So, you know, I think what we've talked about, Kimberly, is if that happens again, as soon as your mom goes to acute care, as a caregiver, you have the right to know what is being planned for her discharge, and they do start to plan that as soon as someone is admitted. So you're very, it's okay for you to ask, I want to know what the plan is around, you know, my mom's stay in acute care and her discharge. Because you're right, I mean, that can often involve you being prepared in the home, or, you know, having to get equipment or meds or any number of things. So I don't know, Wendy and Sheila, if you have any other thoughts. And then Vivian talked about having some, you know, planning that would have involved some training on lifting and transferring. And, you know, this is an interesting one, Vivian. As I mentioned in the chat box, we did a webinar on that very topic. And, you know, it's been one of our least popular webinars. And yet we know that so many people need to know this. But I guess maybe it's one of those things you don't know until you're there. And maybe, you know, we're always working with the healthcare professionals to help them understand what resources we have. We did the webinar in partnership with Safe Care BC, and so it was an excellent webinar. Yeah, so it's, you know, sometimes it's also about anticipating what you might need, and that can be really difficult, but boy, oh boy, yeah, that's a very good point.
I'll quickly just jump in. First of all, Dana, thank you for supporting the importance of keeping a written log of every visit to the medical team. It really does help. So thank you for validating that. And it's great to hear other family caregivers using this approach. I know many family caregivers, you know, that are using this method. I think the part that's really challenging is I would almost say it's habitual. It's one of those, it's like, I kind of put it in the same category, and you're going to laugh when I say this, but I put it in the same category as my like dealing with my mail. You know, so if my mail comes in and it's a bill and I don't, you know, file it, or it's not a habitual routine, I don't follow the same process each time, then I lose track of where, you know, some of those bills are. And so in a way, keeping track of medical information or medical records or it's the same thing. It's having the process in place and following it each time, because it is habitual, especially if we're not, you know, I was never trained in file management. I know that seems basic, and maybe I'm embarrassing myself by saying that, but it's the same thing. Like, we're often not trained to be a caregiver, but we often have skills that will apply, and it's having the processes to put in place. So, you know, thank you for that, Dana. I think it's also really helpful for the caregivers. I did see, you know, with regards to the acute, you know, being discharged without a plan, and then we have a comment from another participant saying, when is the best time to connect with the discharge planning team? I mean, those are both questions, and Sheila, I'll let you jump in a second. Based on personal experiences, you know, what I have found with regards to discharge is that, you know, typically they'll say, well, when someone's admitted to hospital, they're starting the discharge, you know, they're starting that idea of discharge. That's the idea. But when it actually happens, of course, is when that person is arriving to the point where they're meeting that criteria for discharge. And it's going to depend on, you know, what that is, depending on the person's illness. So typically, I usually ask, or if I'm working with families, I try and start, you know, fairly soon, just to get kind of rough ideas on what they're thinking in terms of how the person is progressing towards discharge. Like, even understanding that, you know, where they're at in relation to being able to do those tasks that are going to allow them to be discharged. Whether it's post-operation, whether they're frail elder and they've fallen, whether it's an individual who has experienced, you know, hallucinations or a psychotic breakdown. There's all, you know, sort of the criteria is very specific to what's happening, in the situation. But I find, talking about it sooner is better in terms of, understanding that that's typically the goal, is to have that person discharged.
Wendy, who do you talk to? Who do you approach in acute care? Like there's a whole raft of people in there. So how do you find out who to talk to?
Well, in my experience, and again, what I have found is that it often depends. So, but I usually go to, if I'm looking for like information on tests, or if what the, kind of the process is, I will go to either one of the nurses who's looking after that specific room, or if there's a clinical nurse leader, I'll start there. And if they say, well, I can't give you information, you have to wait for the doctor, then I'll say, okay, well, I'm going to be here for the next half hour. Can the doctor come to see me if they're available? If not, I'll ask what time are they going to be there at, and then if they require, to be called, then I have to transmit that information. So I find that sort of consistent approach seems to be, and I have found that some of the staff, especially the RNs, will is very discretionary in terms of what they'll provide. They'll often say, well, I can't give you the results of the test, but this is sort of what I know. So, and then I try and find out if there's other key people like occupational therapists or physiotherapists or other individuals involved in that. I'll try and find out when they're coming to see the person being cared for, and then trying to make those connections. I would say hospital is a very difficult place because it seems to require that you have to be there for an inordinate amount of time just to find the right people to speak to.
Now, maybe Sheila can answer this. So what about the liaison nurse?
I have always found, if you have a liaison nurse involved, when they will call family care conferences, and they will call the case manager, or because the person is going to be either coming home to need home and community care, or they've already been involved with home and community care. So we were always involved in that care planning, and it was really good because all of the key players, so all of the personnel who have been involved with the care recipient, the patient in hospital, would be at that care conference, or would have sent information to the conference if they were unable to attend. And you would get everybody's care plan. So you would have, if the physio and occupational therapists were involved, you would have information from them. They would be there. They would provide their information. They would provide we would ask for the family, we would ask for, if they hadn't already asked, for what the needs were, if they were going to have to get equipment or make modifications or adjustments to the home situation. The family member would be involved in that case conference, and they would be able to ask their questions. They would be able to probably already had given their input as to what the home situation might be like and what the barriers might be. And then the therapists have to work around that and come up with suggestions that are going to work or not in the home situation. And they're very good at doing that. They really are very, very good. Liaison would also bring in the physicians or specialists involved. We would sit down with all of those people as well. Now, this is sometimes those care conferences, those discharge planning conferences are quite large. Family members perhaps might feel overwhelmed, and that's when we always hope that they bring someone else along with them to and give permission to come to this family care conference, because it is overwhelming. It would be extremely overwhelming, and you need someone there to be another advocate, to listen and take information in, maybe take notes for them as well, so that when the family member at the end, and they think, I don't remember half of what was said, but if you had someone there also taking some notes, then you might be able to have all of that information, and it would be much easier. Liaison they do a tremendous amount of work in discharge planning. looking at all resources. They help families and caregivers with the appropriate places to go to get whatever it is they might require. Social work can also be involved and help through some of the financial concerns, and also looking at other resources for people to tap into in the community. It's a huge team effort, and sometimes there's more than one of those family caregiver meetings. I've been to several. In fact, for one client, I can remember for one patient, it took 2.5 years. It was a very, very lengthy process, but in the end, it was so successful, so very successful, but a tremendous amount of work by the liaison staff, the rehab staff, home and community care, case management staff, and the other healthcare provider we were working with that happened to be an assisted living site, and with the folks from there as well. And we then had to integrate the hospital staff with the home and community care staff, so we had this intersection. Yeah, it was a tremendous amount of work, but it was so successful.
And was there a family caregiver
Yep,
involved?
there was a family caregiver, there was a son involved, and you know, he was amazing, and he had all kinds of support, and yeah, it was really good. And he was very involved, so it worked out really well. We had to, you know, we need that. We need everybody there at the table talking and saying and laying it out so that it can be a successful transfer. Now, we were talking someplace or another there. Yes, sometimes, you know, it's in and out and in and out and in and out, and nobody's listening. And that's when you have to go to them and say, whoa, I don't want this to happen to my loved one again, because we've had this many failed discharges from hospital. We need to sit down and talk about how we can make it so that it's not going to fail, because it's not fair. That's not fair.
That was Kimberly saying that,
Yeah.
but Ruth is also saying, and so maybe this
Yeah.
is a slightly different situation, not in a hospital admission, but in and out of emergency.
Yep.
So in the emergency department, would they have the same kind of discharge planning process, or is it slightly different?
And it's slightly different. And again, if the person hasn't been a home and community care client, the liaison who work in the emergency department, unless they're going to need some set up help in the home, like if they're going to need a therapist or a nurse or someone to go in pretty much immediately, they will just be discharged, unfortunately. And I have seen that happen many times, sometimes 2 or 3 o'clock in the morning, and away they go.
Right.
And, you know, they send them home with a script for meds. Well, good grief, this poor little soul who is maybe 90-odd years old, by the time they get home in the kerfuffle, they've lost that prescription altogether, and they don't, or they tuck it somewhere and they don't have any idea what's happening. It happens, unfortunately. Liaison, if there is a connection with home and community care already, then the liaison discharge nurse would be involved. However, liaison at this point, usually, well, here anywhere, I'm talking Island Health on Vancouver Island, liaison do not work 24/7. So
and Sheila, I think it also depends on, you know, where you live.
Yeah, it does.
Because, you know, depending on the hospital or depending on, you know, where you're at, that staff is. So I think, you know, what I heard you speak to prior was there are often resources there or people there. It's often maybe more about speaking up and asking, you know, do you have someone here that deals with frail elders, you know, staff that I can speak to about how to get more care for, you know, so-and-so? Do you have, because it's often trying to figure out what is the name or what's the title of that person so that you can, you know, connect directly. And I think in Ruth's situation too, you know, I think part of the challenge there is that sometimes, you know, people arrive at the emergency and then they're discharged, but the family caregivers never called, or they do get called, but they've already been discharged and they're just there to pick up. And so in that instance, I would also say it would be really helpful for that family caregiver. Like, you can still go back in and speak to the physician that saw your parent just because they've been discharged. You can still go back in and find out exactly what transpired. They're often, I find anyway, in Emerge, this might be more of a small town situation, but usually the staff are happy especially if a frail elder presents. They're usually very happy if a family caregiver is present to be able to give information, support what's going on, or ask questions or clarify, because it's often just that. I actually think sometimes staff overestimate the abilities of people who come in. They often think, because we know that individuals can often present fairly well unless you have a pretty lengthy conversation with them, where they'll often, rise a bit more to the occasion unless it's something very acute, or they're not able to describe exactly what's going on and it doesn't seem maybe as serious, and so then they get discharged. So I did want to, bring up that point that sometimes it takes a little bit of detective work to find out who the person is to talk to, and don't be afraid to go back in and ask to speak to the person that saw the care recipient to explain some things, because you want to avoid this, happening again, and this has happened in the last 6 months, 3 times. So it is having being that advocate and that voice. Are we good to go to the next slide?
I'm just going to interject here and say, if anybody needs to take a break from the strain of all of this and just look at it with a different lens, we have Janet Dunnett in our guest room tonight. And Janet wrote a book called The Dwindling, and it's a lovely book. It's about the dwindling of her parents. And honestly, I mean, you have to be able to smile sometimes. So have a look at her book, because it does that. It helps you get through some of the tough times. Thanks for being here, Janet.
So I think the second piece is around being a voice. And obviously, I think one of the challenges that we often hear from family caregivers is that the person that they're caring for can be reluctant about having someone attend their medical appointments, or taking over or making decisions on their behalf. So often that's a first place is trying to have that discussion and coming to a place with the person you're caring for and establishing what your role is. Their partner in care. Are you going to take notes for them? Are you going to provide emotional support? With the hope that at the very least that you are present in those critical appointments. It may start as being an active listener and taking notes, and it may end up moving towards a different role. One of the key pieces though is how to formalize your role, and that often is different in each system. So I know, for example, when we're looking at visits to a general practitioner, they typically have their own processes where the person you're caring for, gives you permission to be able to obtain information. In the hospital, it's a little bit different, and in the community, it's a little bit different. So I think, Sheila, I don't know if you want to speak to that point around, how, best ways for caregivers to formalize their role in community health services and human health authorities.
Sorry. Yeah. In the community, if you're the caregiver in the community, what'd she say?
She just wonders, how to form, is there a need to formalize that agreement? Like, who's going to need to see papers? Or?
No, you don't need the paperwork. Yes, you do. Actually, sorry. Yes, you do. So if you do have to formalize your role, and if you do have papers in place, so if you have power of attorney, or you have a representation agreement with your loved one, then yes, it is very important that you provide that information to the case manager, the health authority, or the liaison, or whoever you're dealing with in the health authority when they're starting to set up care for your loved one. And to be a partner in that, they do have to have that information, because if your loved one is able to say, well, yes, I want my son, daughter, niece, nephew, whoever it is, to be my advocate, and I give permission for you to speak with them and tell them anything that needs to be said, unless your loved one can do that, there is that constraint that they really aren't allowed to get information or give information to you as a caregiver unless they know what your formal role is, or either verbal permission has been given, or certainly they would be more inclined to be looking for the POA and the rep agreement. But yeah, and it's really important to let them know that you are the caregiver, and that you you know what you have been doing, what you can do, what you're prepared to do, and to be there, absolutely, so that each time they're going to do an assessment of come and visit with your loved one, maybe looking at care plan changes, because sometimes the care recipient will say, well, I don't want this anymore, I don't need this anymore. It's really important that the team as a whole has everyone at the table so that they can get your perspective, because you as the caregiver are the one who probably see that patient or that care recipient more than the case manager, and they know what it is the person can do or can't do, and how they're reacting to certain things in certain situations. So it's really important to formalize your role and let the case manager know who you are and how much of a role you're playing in the caregiving of the care recipient of your loved one. So yeah, it is important to formalize.
Great, thank you. And again, I think with hospitals, it's often a little bit different in terms of those systems in place. I've come across situations where I've gone up and I've seen the person that I've been providing support to, and have asked the physician, on call, and we've had we've gone into the room, and the person I was supporting said, yes, you can give her any information, and that was just fine. I had another incident where I spoke to a physician. I had to go downstairs and fill in paperwork and get something faxed from the adult child who lived long distance, and other situations where I was able to obtain information from a nurse. So I think that's often the challenging piece, is figuring out, each silo has these different systems, and it's figuring out, well, what do you need to be able to be a voice, and how do you go about formalizing it? And if there isn't necessarily a formal route, how do you go about it in a way that ensures, obviously respect, and that it's in the best interest of the person being cared for, of course. The only other thing I wanted to say, it's actually completely gone. So we'll go on to the next slide.
I'm glad I'm not the only one.
I think it was good. Oh, gosh. All right, Sheila, I think this was going to be your slide.
No, but I'll take it.
Okay.
No, it's okay. I'll do it. So being prepared, it's really important. And Wendy touched on this a little while ago, in saying that when we were talking about making lists when you're going to visit with the family doctor, keep a journal, or keep some sort of way of knowing what has been said, what has been done, what's proposed for the future. So being prepared, develop an action plan with goals for the care, and that is for you. That is when you're speaking with the physician, when you're speaking with the case manager, for instance, if you're dealing with the health authority, with home support workers, with whoever it is. the pharmacist, all of these people are part and parcel of that healthcare team and very important pieces of it. So you have to have this action plan with the goals. Maybe it's just, okay, now mom or dad or husband, whoever it might be, had an appointment with the doctor on such and such a day. You mark that down in your book, you mark it down maybe on a calendar or put it in your phone or wherever you keep these appointments, and look at what happened at the last appointment that you had, what were some of the, what the plan was at that point in time, things that had to be done, make sure that those were done, and then part of your action plan going forth, maybe, if you're going to see the doctor, is follow-up. What happened? So-and-so had blood tests done, for instance. What was the outcome? Sometimes when you get to the physician, they may forget what on earth you were there for this time. It's up to you to keep that little plan going. Look if it's dealing with home support, for instance, and you have someone coming in, they've already been in, the home support supervisor's been in, asked you a whole bunch of questions, again, repeat of things you've already told the case manager probably. They're set up a care plan. You have the right to know what that care plan is. It's usually posted in somehow in the home, in a booklet or someplace where you can look at it and see what they have developed for your loved one. You talk to your loved one as well and see how things are going with that care plan, with regard to that care plan. And if things are not going so well, or you feel that they need a little bit more added, or maybe sometimes something can be taken away, then the next time you are having a meeting, that's been planned for to meet with your loved one, the case manager or the home support supervisor, you have written this down. You may have your questions there. You may have your comments about the care plan. Then you let them know that too. But you do that in, as Wendy said, perhaps in point form, so that you don't have to have great big reams and reams and reams and reams of pages. And I've seen that from a case manager's perspective, seen reams of pages that would have taken me a month to go through. Whereas when you sat down with the person and said, now can you just tell me concisely what it is? And they would just give me the point form, and you can go get so much more done, and it makes a whole lot more sense usually. So people, both caregivers and care providers, time is of the essence, and you want to be sure that you get your most important points across in the time frame that you do have, so that that care for your loved one is going to be optimum. So again,
I think so that applies in all interfaces with the healthcare system. So whether it's a medical appointment with a GP, with a specialist, with a case manager, with someone who's providing clinical counseling, or if you end up in the emergency department, those same principles apply, because that's often what I have found is we're trying to convey as much information, the most useful information for this specific situation in the least amount of time, even though we don't want to feel rushed. We also understand that we have a limited time, a limited audience, and so being prepared is really, really helpful. I just want to generalize it a bit more.
Yeah, absolutely. It applies to every situation really that you might find yourself in as a caregiver. And the important piece is, and again with time management, the most important questions first, the most important issues first, and you have to prioritize those. And the next point where it says be aware, you can also approach a concern as a discussion versus a question. So sometimes that happens. Sometimes it does happen. You're just chatting away, and it can just be a little discussion as opposed to a question. Oftentimes those sessions are great, but again, be sure and get those most important points into that discussion so that you're dealing with those first, and being always mindful that everybody's time is really important. And unfortunately, in this day and age, we are very aware of time and you know, how important it is to get our stuff across in a timely manner. And again, here it is. Keep a written record of questions and answers and conversations with contact information. And again, a little booklet is often a good way to do that. Or if you're really tech savvy, you know, you can keep it on your tablet or your phone or your whatever you're using. But it's important to do that. And then you can tick your questions off as they're answered. And, you know, keep another record of what that result was, and if it worked or it didn't work.
One thing that
information is important. Sorry.
One of the things that one of the participants had spoken to, I think it was Vivian, was, you know, using her phone, and that's something that I've often found too, especially going into medical appointments. And actually, almost, you know, if anytime I'm visiting a client in home and there's a concern that I need to follow up, I'll often take a picture of, you know, if there's something going on, you know, especially if it's something visible. You know, I have, you know, kind of very kind of specific areas where it's like noting changes. Is it worse, you know, since the last time I was here? And then, you know, I always just take a picture of the prescription labels so that I don't have to worry about writing things down. And then it just makes it sometimes a lot easier when you have things all right in front of you when you go see a medical appointment. Or especially in the case when something's happened, there's been like a wound, and then you get an appointment a week later and the wound like has changed, and you want to show them what it looked like at the time that, you know, that you were concerned. So sometimes I find, you know, those little valuable points, you know, can help around those specific areas. And Sheila, I'm sorry, I threw you off. I got my slide numbers mixed up.
That's okay.
So being realistic, you know, I'm going to hand this one over to you, Sheila, and then I'll jump in just because it's up your alley.
Yeah, it is all about collaboration, and that's a huge word for all of us who are in the healthcare system at some point, and still, but collaboration is really, really important. It's about working with the healthcare providers and to meet you and your health and your care recipients' needs. And again, it's really important to be clear about what help you need. Healthcare providers, they can't arrange everything, but they certainly can help with information. And as I said before, you know, if a physiotherapist or an occupational therapist is involved and equipment is being needed, they certainly will give you that written information. Now, someone asked a little about training in, what was it, lifting?
Right.
Yeah, so let's say it could be in the acute care, it could be at home. You can ask for that. And if your person is, you know, your care recipient is in need of lifting or transferring, you can certainly ask your case manager or the therapist just for a little time to show you how to do that so that it is safe for both the person you're providing care to and for you. So I know that the therapist will do that, so you can ask for that. So please, you know, that's your voice. So use your voice wisely, and they will help you. And they will give you the information that is required. If some equipment is needed, usually if the person is on home and community care and equipment is needed, the therapist now, just about every case manager can order equipment from a provider, be it a loan covers or the Red Cross or whatever. If buying equipment is needed, usually that would be the therapist who would be writing that information down for you and giving that to you. And then you would take that. They can't recommend specific providers, but they certainly can give you a list of providers in your community. Doesn't matter where you are in the province, they can do that. That would provide the equipment for you. And just keep in mind that sometimes sometimes, although you think that as a caregiver that your care recipient should be getting more help or whatever it might be, that the providers they're following policy directives. And there are parameters within which they have to work. And sometimes it just seems that it's just not right and it's not enough. Believe me, from a former case manager, that was very difficult to deal with because we always wanted to do as much as we possibly could. However, there are limits to what we could do and we couldn't do, to what we could provide and what we can't provide, just because of the resources that we had. And I think that we all understand that there are limited resources, and we have to share that wealth among a lot of people. And sometimes it just doesn't, to us, if we're, providing care for a loved one, it just doesn't seem enough. It's the best that we can do, and it's made to be fair as we possibly can to everybody within our province. And those are the, we have to be realistic about that. So don't shoot the messenger, work with them as best you can. It was tough for us too on the other end, wanting to do more and not being able to. But with some creativity, we managed some great stuff. Right, so work together. There's the collaboration. Work together to provide the best for your loved one.
And I'm just watching our time.
Yep.
And I think this next slide is a lot of what you're talking about, Sheila.
Yep, it is. I think it always pays to be very polite on both sides. And every health authority has their little thingy that says we do not blah, 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 blah. And they, you have the right to be respected, and you in return must respect as well. So all the health authorities have those little things. We all had them written on our little badges, and we were very, very aware of them. So being polite and persistent is it's paramount, really it is. And be positive as much as you can, because we don't want to be thought of as a whiner or whatever, because we hear a lot of that. But present your ideas positively, be proactive and goal-oriented. We talked about setting goals before. Have your goals, think of those, where you want to go. But I think what the one piece that we're just missing here, and I just want to put it in this whole process, we must always remember to include our care recipient. The person we're providing the care for, they are the center of this whole process. Remember to keep them involved and apprised of what is happening and what the care plan is going to be. Sometimes that you may feel that they don't understand, but they're the pivotal piece of this whole caregiving journey. So please always remember to include them.
I always like to remind myself or ask the person I'm working with to think about, like, are they pushing for the care recipient, or is this really about them at times? And I think that's also, it can go both ways, because there are times where caregivers do need to say, so-and-so is living at risk, and although they can direct certain aspects of their care, this is their fourth time, here, and I'm the one having to pick up the pieces. So it also then comes down to, what, as a caregiver, it comes back to that whole piece we talked about, what you're able and willing to do as a caregiver. Is there anyone else that can provide the support? So I think that, that piece is also important. And I agree with you, Sheila, about, being positive, but I also really believe that we don't want to be pushovers as well. We want to make sure that we, ensure that ourselves as caregivers are being protected, that we're presenting things in a positive manner, that we aren't, but that we're also making sure needs are being heard in a very, factual, objective way, with maybe less of the emotional piece that can sometimes creep in.
Yeah, absolutely. And don't give up. Persistence does pay off in the end. Sometimes it seems like, sometimes you think, oh my goodness, I can't do this anymore. I really can't do this anymore. Like, I don't seem to be getting anywhere. However, persistence does produce results. So stick with it and don't give up.
So it looks like we're not going to get to the remainder of our slides here. We wanted to have that extra, healthcare speak. Okay. I'm just looking at our time. It's almost 8 o'clock. So what do we want to do, Janet?
Well, I think we could quickly cover off some of these points, but I really want to say I appreciate the chat that we've had in the chat box. I think it's been really helpful, and we've had some great tips. And I would encourage you to, certainly you could come onto our website if you want more information or you want to add more points. I'm always looking for topics for our newsletter that comes out quarterly. We can keep the conversation going. So, Sheila, why don't we let you cover off some of these key points about healthcare speak.
Yeah, I'll do it really quickly. An assessment, when we're talking about an assessment, it's a paper tool that is done. It's got 100 questions probably on it, something like that. Tick boxes, case manager comes in. As a result of that assessment that they do, this whole question thing that they're asking, the care plan is developed. And then that care plan is sent to the home support, going to provide the care to the healthcare recipient. Referral process, understanding the referral process, who's making the referral, what is your role, what is the expected outcome. It's a call to the general inquiries line that any of the health authorities, anybody can make a referral, anybody at all, as long as the recipient is willing to, has given permission for that referral to be made, and that they're willing to accept an assessment if it is going to happen, if they're eligible for home and community care. What would happen is that the case manager or if nursing or whoever they made the referral to would then contact the client or the person making the referral and make an appointment to come and visit, and then go through that formal assessment process.
And I think we've covered some of these other
We
points.
have.
So at the beginning of the webinar, we mentioned that we did one that's already posted on our website on accessing community resources. And in that webinar, we went over, some of the information about different scopes of practice and who does what. So definitely go and take a look at that. As Wendy pointed out, we are at 8 o'clock, and I think we need to